Good morning, everyone. Today we are going to discuss a very common topic which we encounter in our almost every day, in every day daily life, including not the gastroenterologists or hepatologists, even the internists, even the doctors who are practicing this for GIs, like GI surgeons, general surgeons. They encounter this most common word, which is fatty liver, which is being commonly written nowadays on ultrasound. So basically, today's we are going to discuss which is non-alcoholic fatty liver disease, and by definition, we call it as presence of fatty liver or steatosis at least 5% of the hepatocytes. But in the absence of significant ongoing or absence of alcohol consumption and other chronic or other liver diseases. But this definition requires a liver biopsy. This requires histology to confirm whether it is there or no. Second important point is the absence of alcohol use or any other liver diseases. But how do we depend on it? Like it depends on the patient factors. Like, is it the patient is truly telling you that he's taking one drink, two drinks, or 10 drinks a day? And there are no specific biomarkers, there are no specific cutoffs, and there's no differentiation between social or the binge drinking. So one person is taking one drink, some one person taking 7, 8 drinks a day. So there's no basically a clear cutoffs. That brought the people, the experts into the field, like to basically to define it in a more objective way. And they turned out and they came with a new definition, the NAFLD to the MAFLD, like which is metabolic dysfunction associated fatty liver disease, which is very common to have it. And nowadays almost NAFLD is being replaced by the MAFLD, like metabolic dysfunction associated fatty liver disease. So what is the objectivity in this MAFLD? Why do we call this being more objective compared to the NAFLD? It includes the presence of hepatic steatosis or fatty liver disease on the basis of three things, whether it's histology, it's imaging, or some blood biomarkers. Any of those, if suggestive of fatty liver disease, we'll count it as a fatty liver. And and there are three more criteria which we include, like if it is patient is overweight or obese. Second, patient is overweight, obese, or type 2 diabetes mellitus. And third, there are other metabolic dysfunctions like metabolic markers that we go through now. If you see on this overweight group, and second the type 2 diabetes mellitus group. But in the middle, we have a group which is lean or normal body weights. But there are some metabolic features like difference like waist circumference, like central obesity, which is very common in Asian population, hypertension, high triglyceridemia, HDL is low, pre-diabetes, or their insulin resistance documented by the insulin level or the HOMA IR index, and high CRP, high sensitivity CRP of high more than 2. They're all grouped together to called as MAFLD. And as my topic was an epidemic, yes, it is an epidemic. The burden of disease is huge. If you count this, the prevalence is more than 30% in certain pockets of the world, and which includes the Southeast Asia, which includes the Middle East region, certain parts of US and South America also. So substantially, there is increase in the incidence and prevalence of this NAFLD or MAFLD. And it was said that the number one cause of liver transplant was hepatitis C at a certain point, but after the advent of new medications for hep C, it has been replaced by the non-alcoholic fatty liver disease as the number one cause for the liver transplantation worldwide. This is another slide from another study which also documented to have 31.8% of non-alcoholic fatty liver disease in the Middle East region. And worldwide, the prevalence is around 25%. Another study from the University of Washington Institute of Global Burden Disease, they said the prevalence from 1990 to 2019, it has increased by 52% and incidence rate has increased by 121%. And the hot pockets or hot spots of this non-alcoholic fatty liver disease, the MENA region, means North Middle East and North African region. And in among those, the Bahrain has a 37.1%. There's another study which mentions about the prevalence of type 2 diabetes mellitus, which mentions about the Bahrain is almost 19.9%. There's one more study I found from Bahrain, which showed non-alcoholic or NAFLD is present in diabetes mellitus almost about 68% of the people. Quite high. In worldwide, it's around, we count it as 55%, but in Bahrain, it's 68% roughly. So, it being so common, we cannot cause it is second into something else. Usually, there are dual etiologies. Like something is there along with the non-alcoholic fatty liver disease or NAFLD. Patient may be taking alcohol, but he might be having also underlying NAFLD. So this is called a dual etiology concept or dual etiology fatty liver disease. So the patient who is meeting the criteria for MAFLD and any other cause of liver disease, which includes alcohol use, viral infections, autoimmune hepatitis, inherited disorders, drug-induced liver injuries, or others like Wilson's and others. So the term which is non-alcoholic steatosis or non-alcoholic steatohepatitis, NASH or NAFLD, is being almost replaced by the new term called MAFLD. Now the disease severity in this MAFLD should be graded according to stage as we used to do in NAFLD. There's a concept we always call some diseases as secondary causes, like having rapid weight loss can lead to surgical, like bariatric surgery can lead to certain diseases like lipid metabolic disorders can lead to the fatty liver disease. These are among those lists which can cause a secondary, rather than we should say alternative causes, rather than secondary, we should say alternative causes of fatty liver disease. And one of the case report from my previous institute, we reported the celiac disease patient with the microscopic colitis developed NASH and subsequently NASH cirrhosis. Now we know the NAFLD, we know MAFLD, but what causes somebody to have NAFLD or MAFLD? There are certain parameters, certain mechanisms which work on it, like genetics, lipotoxicity, gut microbiota, or dysbiosis, and insulin resistance. Among genetics, there are certain genes which are associated with the fatty liver disease, and common among those are PNPL, PNPLA3, which is very common, another is transmembrane super 6 family, and MBO87 also. These are among common ones which we encounter some of the time, but only done by the geneticists who are working for it. The other common cause is lipotoxicity or lipid toxicity. And as we know, the life is a balance. And then the balance goes out of proportion, results into the toxicity. Similarly, here there is a lipid disposal or metabolism and imbalance between the lipid uptake. Ultimately results into the lipid deposition into liver. What happens once lipid deposition, which usually comes from the diet, fat, esterified fat, or even lipogenesis, which happens in the body in the absence of insulin or in the presence of insulin resistance. So main and proximal event in the MAFLD is accumulation of free fatty acids in the liver. As Dr. Najam mentioned that the abundance of food has also significantly affected it. The lifestyle, abundance of food, sedentary lifestyle, which all has come to the overconsumption of nutrients, resulting into the adiposity, specifically visceral, which decreases the adiponectin, which is a hormone. If it is reduces, it increases the possibility of pro-inflammatory cytokines, which causes the high CRP and leading towards the NASH. And similarly result into the fatty liver, steatohepatitis, and insulin resistance as well. This accumulation of free fatty acids usually results into the generation of fatty oxide oxidation and reactive oxygen species, which can lead to the damage of the endoplasmic reticulum and the mitochondrial pathways, ultimately resulting into the NAFLD into NASH and subsequent follow-up of like fibrosis and others. The third concept is gut dysbiosis. Dysbiosis means the change in the bacterial flora which we have. So it's nowadays considered also a significant microbial signature for the genetic purposes. And as we all know, up to 75% of the circulation for the liver comes from the portal, means from the gut, which that's the reason this term is called gut liver axis. And whatever we take, food, xenobiotics, medications, nutrients, all has to cross through the liver to be metabolized. It's the first station to be to metabolize all. And this disturbance is called dysbiosis, which can regulate the inflammatory cells like Kupffer cells, promotes the production of short chain fatty acids, and alter the intrahepatic circulation of the bile acids or bile salts, ultimately leading to the inflammation and steatohepatitis. The further evidence we got this from, like, it is said that steatosis is associated with reduced diversity of the gut microbiota. And some studies from the bariatric surgery, they have mentioned that there were some certain bacteria with like anaerobic commensal bacteria, Faecalibacterium, Akkermansia, Robusteria were found higher or enriched in patients who has undergone bariatric surgery. So this sort of microbiota also can be used as a signature for microbial who are who have a tendency to develop fatty liver disease, MAFLD, and NASH cirrhosis subsequently. And the fourth one is the very common and which shares the same pathophysiological mechanism between the type 2 diabetes mellitus and MAFLD. It causes resistance to anti-lipolytic effect of insulin. Ultimately, insulin cannot work as a lipolytic agent, so anti-lipolytic agent, result into the insulin resistance. And the most common reason for type 2 diabetes is also skeletal muscle insulin resistance. So they share the mechanism of the same. And type 2 diabetes mellitus patients usually have higher circulating free fatty acids, which are going to deposit in the liver and resulting into the steatosis followed by steatohepatitis. Even in those people, the liver insulin clearance is also reduced or inhibited in type 2 diabetes and certain cases of metabolic syndrome. As we saw, nearly 55% worldwide people with the type 2 diabetes have fatty liver disease, and in one study from Bahrain, it was 68%. So it's worthwhile to rename the NAFLD to the MAFLD. And definitely it causes you to better understanding in terms of pathophysiology for type 2 diabetes, insulin resistance, and further treatment and all follow-up. So this is the brief of the pathophysiology, NAFLD and MAFLD, which includes genetics, lipotoxicity, insulin resistance, and gut dysbiosis. Now, we know the NAFLD. How do they present actually? Usually they have no symptoms or mild dull ache, or if they are fairly advanced disease, or there are some metabolic features which we have to look into. Therefore, we should always be vigilant in like people who are mildly obese, even not obese, but having fatty liver disease. Are they having high blood pressure? What's their weight circumference? Is there any central obesity? What about the triglyceride level? What about the other lipids like HDL, CRP, especially high sensitivity CRP? As I said in a previous slide also, that this is also inflammatory condition. Adiponectin reduces and the inflammatory cytokines increases, which also can cause high CRP. And insulin resistance, which can be documented by insulin level or HOMA-IR index. So these are three categories of hepatic steatosis. One is with overweight, diabetes, and the one which is a middle one, lean or normal weight people which having metabolic features, which we have discussed, and ultimately to be diagnosed as MAFLD. Generally, they have high blood pressures, higher circumference, triglycerides, all high enzymes. Now, there are two ways of looking into it, whether it's liver specific or extrahepatic, hepatic or extrahepatic. Extrahepatic means having a cardiovascular disease, obstructive sleep apnea, chronic kidney disease, polycystic ovarian disease. They all come in the category of extrahepatic manifestations of fatty liver disease or MAFLD. There are higher chance we find these situation in MAFLD. When we look for MAFLD, we are mostly NAFLD, we are specific for the liver. When we talk about MAFLD, we look into the extrahepatic things also. Otherwise, the hepatic things for both the cases are same, like fibrosis, fatty liver, cirrhosis, HCC, all are same. But extrahepatic makes a difference. In subsequent slide, I also show you how it is important. So one study has confirmed that the steatosis, and whether in case of hepatitis, fibrosis, are almost same as we saw in the previous slide. Another study showed they are independently associated with intrahepatic and extrahepatic. Even it is said this MAFLD itself has a higher hazard ratio for cirrhosis, HCC, cardiovascular disease, and renal failure or renal disease. So there are studies which favor that MAFLD can be a better as a marker for the extrahepatic and intrahepatic, and some says no difference. There's another study which showed that people who have MAFLD, they have worse outcomes compared to the NAFLD. So we should pay attention, especially the metabolic features. These are the different organs affected, like PCO, obstructive sleep apnea, diabetes, cardiovascular disease, kidney disease. And it is said the overall malignancies also has increased, not only the liver, other also like stomach, pancreas, and lungs. So how do we reach to the diagnosis? For the NAFLD, it's an abnormal accumulation of fatty acids in the liver, which is called hepatic steatosis. And for the diagnosis of NAFLD, we need biopsy, which requires more than 5% presence of steatosis in the hepatocytes in the absence of ongoing alcohol or other liver disorders. So it's a diagnosis of exclusion. But in MAFLD, the criteria is different, as we discussed. It includes the metabolic features. So the first and foremost thing, sorry, hepatic steatosis. As we said, the first thing which is the gold standard is liver biopsy, but not possible to do in every case of fatty liver disease. The second way we have to go for imaging, which includes four ways. Like we can do an ultrasound, simple ultrasound, which can tell you the presence of fatty liver. There are shear wave elastography, which can tell you there are certain markers like fat fractions, which we can do on ultrasound, different machines like UDFF is there, like CAP score is there. And on MRI, we have also like same MRI spectroscopy or MRI fat fraction. Fat fraction can be estimated. The third is the steatosis biomarkers. Like there are certain blood markers which can also be used. Which includes fatty liver index, steato test, NAFLD liver fat test. There are certain blood tests which have to incorporate and do the online calculation to find. Among those, the fatty liver index is the most common which is being used. When to consider for status when the imaging is not available and it can only tell you about the diagnosis. But at last, I must say the gold standard would remain the liver biopsy to 100%, which is not possible in every case. So we know it's MAFLD is there. We got to know. Now we have to assess the severity of the MAFLD. We have to assess the fibrosis of this. There are different ways. There are some biomarkers, there are some blood tests, and do some calculation in terms of EPRI score, FIB4 score, or NAFLD fibrosis score, which can tell you how can be a person, how bad is the fibrosis score, how bad can it be. The third way is imaging based, which can be like fibroscan, elastography, transient elastography, which can also tell you. The obese is a patient, the reliability of ultrasound slightly goes down because of thick wall. In that situation, MR elastography is the best to be measured and can tell you the exact what it is. So when we reach to the conclusion that this patient is suffering from the MAFLD, having such amount of fibrosis, and we have to treat it further now. As we said, NAFLD and MAFLD, they are only the liver specific. So there are certain guidelines which are still working on saying it's NAFLD like. But the treatment, liver specific is like weight loss. It is said that 3 to 5% of body weight loss can improve steatosis. But to reverse the fibrosis, you should lose at least 10% of your body weight. The other thing which they mention about is somebody has a diabetes and have the fatty liver disease with NASH, the pioglitazone is the medication of choice at that point. But somebody has no type 2 diabetes mellitus, the choice of changes to the vitamin E. But they are not without the side effects. Long-term side effects are there, which should always be considered. So lifestyle changes remains a cornerstone, whether it's MAFLD or NAFLD. Dietary changes, exercise plans, and weight loss. There are different diets people have tried, like low carb diet, ketogenic diet, paleo diet, Mediterranean diet. Among those, there are different groups of people who are following the different diets. But in our clinic, in our hospital, we follow the low carb diet, which has worked for us. But the question is the compliance with any of the diet, which is the ultimate problem at last. Second point is the physical activity, exercise. 12-week of aerobic exercise intervention has shown significant improvement, especially histologically. And when a meta-analysis confirmed that interval and continuous aerobic exercise may be more effective at improving the ALT and management of MAFLD. So the prime goal is to weight loss, but if we can't do it by lifestyle, we have to help the person with some medication, some interventions of some sort of surgery. So there are some anti-obesity medications which have been tried, but they are not without the side effects. Like one of the medication which was used before was lorcaserin. But in one study, Camilla Timmy 61 study was found that it increases the risk of pancreatic and lung cancer. So it was withdrawn from the market in 2020. Currently approved medication for the weight loss are orlistat, naltrexone extended release, bupropion extended release, phentermine, topiramate, and liraglutide, semaglutide, which is being used now. But they are anti-obesity. We cannot say that it's all for the NAFLD. Yes, indirectly we can say the person, if loses the weight, will improve in terms of NAFLD. So weight loss of more than 10% is overall is beneficial in alleviating in terms of hepatitis, and fibrosis. Now, if we cannot achieve this target by medications, the next option is we go for endobariatrics, like balloons, gastroplasty, or we go for bariatric surgeries, which are different. But that also has own effects. Like sometimes rapid weight loss post-bariatric can also cause worsening of NAFLD and NASH. So that should also be kept in mind, and the person or the physician should be vigilant in that situation. Now the question is this was offered NAFLD. Now about the MAFLD. MAFLD is mostly associated with the cardiovascular diseases and other vascular disorders. So what should we do? We have to target that cardiovascular endpoints also. Like if the person is having some significant cardiovascular disease in terms of angina, that should be looked into, and we require the treatment, we should go for it. We should go for cardiac assessment. So another is the other anti-diabetic agents, like as we recently talked about the pioglitazone, which is recommended for the metabolic associated steatohepatitis in terms in people with type 2 diabetes mellitus. But it increases the risk of fluid retention, weight gain, bone fractures, and certain risk of cancer, risk of pancreas and the prostate. Another option is metformin. Metformin also is commonly being used for the purpose of for type 2 diabetes, for weight loss, and then for the NAFLD itself. Yes, multiple studies which shows like it definitely reduces insulin resistance, it reduces the ALT, it reduces the fatty liver. But histological improvement are like controversial. Some studies say it's improved, some say it's not improved here not improved. So there's a controversy among those. At least we can talk about the metformin is a promising drug in NAFLD, especially in patients who meet the diagnostic criteria of metabolic syndrome, which can help us, especially the long-term use safety profile, which is proven now. The newer anti-diabetic agents like GLP-1 agonists and SGLT2 inhibitors also are showing some promising results in terms of. Therefore, if the diabetes subtype of MAFLD is diagnosed, we should prefer to use these agents like metformin, GLP-2 agonist, or SGLT2 inhibitor, depending upon the sugars. Third thing, as we saw, like it's also associated with the lipid derangement, cardiovascular disease. So statins plays a very good role in terms of MAFLD if it is associated with certain risk factors of atherosclerosis. And it is also said that statins also are antifibrotic in terms of NASH fibrosis. So that also gives you dual advantage. And also reduces the risk of cardiovascular morbidity, mortality, especially in terms of MAFLD and steatohepatitis. Which is nowadays, which we talk about very often about the vitamin D. Vitamin D is a pleiotropic hormone, like same gene works for many, with extensive anti-inflammatory, anti-fibrosis, and insulin sensitization properties. It has been seen that it mediates immune inflammation and metabolism. Vitamin D supplementation had a good effect on glycemic control and insulin sensitivity in MAFLD patients. But one study showed lower serum vitamin D levels are associated with higher prevalence of MAFLD. But supplementation of vitamin D didn't help. It's still under studies like. And one more drug we talk about, well, more liver specific, is vitamin E, which is fat soluble antioxidant which can prevent or repair the liver damage and decrease the steatosis, fatty liver disease. Its function is considered to be upstream from oxidative stress. As I said, the oxidative damage happens to the liver, endoplasmic reticulum, and mitochondria, which can be prevented by this kind of medications. And one other is like a combination of vitamin and curcumin treatment alleviates a diet-related or induced steatohepatitis. A meta-analysis confirmed the vitamin D either alone or in combination with other drugs can improve biochemical and histological outcomes in children and adults with MAFLD. Vitamin E can also prevent metabolic associated steatohepatitis patients with advanced fibrosis progressing to the liver decomposition or liver transplantation. It's recommended for the use of people who have NAFLD but no diabetes. And one clause as per guidelines AASLD or EASL is the patient should have a biopsy proven NASH to use this one. But long-term side effects are there. Like it is said that vitamin E itself is related with the bladder cancer itself. So long-term use is also questionable in that situation. So here I conclude my talk, and like as we talk, it's an epidemic. Yes, the burden of NAFLD has increased substantially as an epidemic, affecting mostly the MENA region, which as we saw in the study in the different from US and the studies, like it has increased the incidence rate from 120% increase and the more than 50% rise in the prevalence rate. And international concern has come to the conclusion that we should use the term MAFLD rather than NAFLD currently, but not all on the same page still. And according to definition of MAFLD, the fatty liver disease can be divided into three categories: obesity, type 2 diabetes, and other lean with metabolic features. And the treatment includes lifestyle modification, liver-specific pharmacological agents like pioglitazone or vitamin E, MAFLD metabolic syndrome related like weight loss medications, statins, antiplatelet agents, bariatric endoscopy, or bariatric surgery. Thank you. These are my references.